Foundation. Their vision is to find cure for Coats disease. Mission is to offer patients hope and improvements as they wage a lifelong battle against Coats disease and blindness. Goals are to build awareness, raise funds, fund research, and build patient resources. Now, it is a nonprofit foundation. It was established in 2006 by parents of Jack McGarner. It was our honor that actually Jack is here today with us in the audience, as well as his mother, Tina. And they promised really to find cure for disease, Coats disease. Now, it's only fitting that our inaugural keynote lecturer, Jack McGarner Coats Disease Foundation keynote lecturer is Mike Jumper, being that he has taken care of Jack. Now, I'm going to tell you a little bit about Mike. His medical school training was at the University of Texas Southwestern in Dallas. He did ophthalmology residency in the University of California in San Francisco, and we share passion for Blue Devils since he did his fellowship at Duke. He then went on to do his chief service in United States Air Force. He's currently a vice chairman, Vitreoretinal Service chief, and Vitreoretinal Surgery Fellowship co-director at California Pacific Medical Center. He's a member of West Coast Retina Medical Group in San Francisco. We know Mike from many appointments, and he's a pretty prominent role within the ASRS as a board of directors, and also editing and leading on some of the really well-known publications, such as Retina Times, as well as the Preference and Trends Survey. He has published over 80 journal articles, chapters in peer-reviewed ophthalmology literature. He's given really numerous presentations and participated in many courses. He's on the editorial board for the ASRS Journal of Vitreoretinal Disease, and he has really served in many scientific reviewer as a reviewer for many journals. He has received many honors, senior honors from AAO and ASRS, and he has been an outstanding teacher, and you can witness that by outstanding faculty awards given by residents that he's taught. So without further ado, I would like for you to help me welcome our inaugural keynote lecturer for Jack McGarner Coats Disease Foundation, Mike Jumper, and his talk will be on Coats disease, our current state of ignorance. Thank you, Mike.
Well, it is really an honor to be invited to speak here and to be given this honor of being one of the keynote speakers. And I wanted to share with you a passion that I developed when I first met Jack with Coats disease, and tell you what we know and maybe what we don't know about Coats disease. I have no financial disclosures pertinent to this talk, but I will be talking about the off-label use of a lot of drugs. And when you're talking about a lot of drugs, it means not one works really well, so that's one of the reasons. The Coats Disease Foundation had its beginnings almost a decade ago, when in 2010, the McGovern family and the foundation sponsored a small retinal vascular disease meeting. You can see some of the familiar faces in the crowd that we met in San Francisco. We did it again 2 years later, and this meeting was in 2012. Their dedication to education and getting people together and networking and learning has been really tremendous. And I very much appreciate that, and all my colleagues that made it out to San Francisco for these meetings. And now here we are today, this big meeting that Emmy has put on, and they've been a part of that as well. It's been a great 10 years, really. And I didn't really appreciate the bottom-up research efforts that are needed for rare diseases until I met the McGovern family. But it's a very important thing that either a solo investigator or a family or somebody with a real vision starts working on a rare disease, or else it won't get studied and it won't get cured. These are a couple of articles that highlight families much like the McGovern family regarding this effort. I'm a clinician, and I'm going to give you a bunch of cases, and I'm going to throw some cases out to start with, and I'm going to come back to those cases as we're hitting on points in Coats disease that I'd like to make. The first case is an 11-year-old Asian boy who had progressive vision loss in his left eye for a month, and it was harder for him to see in the dark. He has a past medical history of asthma, no family history, and his vision was counting fingers in this affected left eye. And you can see pretty amazing exudation throughout the periphery and in the posterior pole. The second case is a 2-year-old who had normal birth and development, developed a right exotropia. It was discovered by mom. That right eye had poor vision, and on examination had a 3B Coates-related retinal detachment. Now, just to refresh the memory of people, this is the classification scheme that had been developed over time and was finally kind of elucidated by the Shields, who have done so much in our understanding of Coates disease. And you can see here 3B means a total retinal detachment. The third case is a 12-year-old boy who had vision loss in his left eye for 3 months, no past medical or family history, and poor vision in this left eye that has peripheral telangiectasias and posterior pole exudation with subretinal and intraretinal fluid. And then the fourth case, a 5-year-old boy who looks very much the same with macular exudation due to temporal telangiectasia. His vision loss was discovered at a school screening. His vision's 2400. The last case is a patient who has distortion of vision, and he was diagnosed with multiple sclerosis and currently inactive without therapy, and was treated for Coates disease originally when he was 26 about 5 years ago, and now has good vision. The macula was never affected, but now has some distortion associated with exudation that's temporal to the fovea. So the original Coates description, we were talking about this yesterday with X-linked retinoschisis. These researchers that happened in the early 20th century were quite good at identifying and characterizing and showing what things look like without all the fancy equipment that we have. And Coates did a good job of identifying this condition as being in young males, usually unilateral, congenital, not familial, and really not associated with any real systemic disease uniformly. But the question is, usually unilateral still hold, and is it really unilateral? Well, there's been some studies that have been done by members of this audience, including Mike Blair and his co-workers, that showed that there are vascular changes when you look with wide field angiography in the unaffected contralateral eye in some Coates patients. These are in the form of telangiectasias and microaneurysms that rarely exudate and are not neovascular. And in a larger multi-center retrospective study looking at 175 Coates patients, they found that 19% or so had this contralateral finding, none of which progressed over time. Going back to Coates' description, there are retinal vascular abnormalities, which we all are aware of, associated with exudation, and this has a tendency to accumulate in the posterior pole. And he also identified the lipid-laden macrophages that are in the subretinal and intraretinal space. So later on, we've had some refining of the definition, and the Shields, in one of their named lectures, proposed that Coates be defined as idiopathic congenital retinal telangiectasia with intraretinal or subretinal exudation and without appreciable vitreoretinal traction. And this was really trying to distinguish Coates disease from the many conditions that result in either retinal telangiectasia or exudation or both. So going back to case one, this is the 11-year-old who's had some difficulty seeing in the dark. His other eye is not normal. He has peripheral retinal changes, and his visual field is abnormal in both eyes. Electrophysiology is also abnormal with abnormal photopic and scotopic ERG responses. So this is a child that has retinitis pigmentosa and has a Coates-like response. Now, there are systemic conditions that have a Coates-like phenotype, including FSHD, senior Loken, Turner syndrome and Alport syndrome. And then there are ocular conditions that also have Coates-like response as well. There's a little controversy in this. I think in some of these conditions it may be that they actually have a real Coates sort of phenotype, such as in Turner syndrome. And we might learn something from these genetically abnormal conditions that we can somehow link up and try to sort of discover what's common between the retinitis pigmentosa or, say, FSHD, that we can kind of better understand the cause of Coates disease, for which we don't at this point. There's an estimated incidence of 0.09 per 100,000 people. That was from a study by Morris in the UK. It's been diagnosed at anywhere from 1 month to 79 years of age, but the median age of presentation is around 5 years when you look at tertiary care centers that are getting referrals, mainly to rule out retinoblastoma and other things, or 8 years when you did the population-based study. There is an earlier age of when there is an earlier age of presentation, there's an increased disease severity and an accelerated progression, and this is almost its own entity in my opinion. And in an advanced Coates series of advanced Coates patients, 40% presented at or before the age of 2. If you don't do anything about Coates disease, it's not good. And so total retinal detachment is common. Neovascular glaucoma occurs in a third of patients without treatment, and Hake reported that 80% of the untreated patients in his study developed ptysis, neovascular glaucoma, or both. So the treatments that we have available to us include ablative therapies, as you know, drug treatments, intraocular surgery, or a combination of all of the above, which is what a lot of people end up doing, some form of combination. Now, as far as ablative therapy, I'm a big believer in the results of this paper and the Bascom-Palmer experience, and that repetitive aggressive laser, I think, is oftentimes a good way to control the progression of Coates disease. In their study, they used a diode laser, and their objective was to whiten the vascular abnormalities, even in detached retina. And when the retina reattached, or in areas of reattached retina, you can place scatter laser in the areas of ischemia. They did a medium number of 4 to 5 treatment sessions, and they applied the treatments about every 2 months. And they had very good anatomic outcomes, and this is what I feel has been helpful in my practice, and I employ much of the time. Laser has long-term good anatomic results with alone as a monotherapy, and we find that using intraoperative wide-field angiography can help identify the extent of the disease in the areas of ischemia that may not be so easy to see on examination alone, which then I think reduces the retreatment rates. Cryotherapy has been traditionally used for stage 3 and 4 disease, and I think it still has some role, but I don't use it much. It may temporarily increase exudation, and I would just caution that people be careful when using it with combination of drug therapies. Intraocular pharmacotherapies, the rationale is that angiogenic and bioactive factors have been found in the fluids of Coates patients at higher levels than normal, and you can see the list of the agents here. VEGF levels, interestingly, are higher in the pediatric Coates patients than adult Coates patients, which may explain this different phenomenon that you have in the younger patients with greater exudation and problems. Now, steroid therapy has been used primarily intravitreal triamcinolone has been studied with mixed results as a monotherapy, and there have been a lot of complications reported when it's used in combination with cryotherapy. A study by Bergstrom helped to let us understand that. They found elevated intraocular pressure in 4 or 5 of the patients that they treated with intraocular triamcinolone followed by cryotherapy some months later. There was severe cataract in 3 of 5 patients. And then even long-term, there was development of traction and retinal detachment that was inoperable in 3 of 5 patients. So I would caution people to avoid the use of intraocular steroids and cryotherapy. Intravitreal anti-VEGF therapy, I think, has a role. A lot of the different drugs have been used. There's a temporary reduction in exudation, and much like the treatment of proliferative diabetic retinopathy or other exudative diseases that we deal with, it's not a cure, it's a temporary treatment. And so an ablative therapy is often needed in conjunction or afterward. There have been reports of improved vision, but there have also been reports of vitreoretinal fibrosis and progressive traction to detachment reported with the use of anti-VEGF therapy combined with ablative therapy, especially cryotherapy. So again, cryotherapy and these intraocular drugs are something to be cautious about. Now, intraocular surgery for coats is usually reserved for stage 3 or greater disease, and it's been shown in this series of a large number of patients with shields that 17% of those patients ended up, 17% of the eyes ended up needing some form of intraocular surgery in their hands. The techniques go from anywhere from placing an anterior chamber infusion with drainage and then having the reattached retina, using the reattached retina to ablate it with either laser or cryotherapy more often. But then vitrectomy with all the different techniques that we know to use have been employed to try to get retinas reattached with Coates detachments. I'm sorry, this is an example in the literature from Stagna and his co-workers showing an anterior chamber maintainer placed with a 27 gauge needle that's poked through the sclera, through the choroid to allow drainage of subretinal fluid as the anterior chamber maintainer is maintaining pressure in the eye. So colleagues in this room have gotten together and put together a series of patients who, looking at long-term outcomes of stage 3B Coates. You can see here this was 16 patients, or 16 eyes of 16 patients with at least 5 years of follow-up, but it was very long follow-up with a mean of 9.5 years. The interventions were all of the above, including ablation in all of them. And then vitrectomy was performed in 12 eyes, 8 of which had vitrectomy within the first year of diagnosis, and 4 of which had what they called late, which was average or a mean of 3 years after the diagnosis. The outcomes are disappointing, but what we see with no light perception or light perception vision in 8 eyes, counting fingers vision to 2,200 and 25%. Some of the patients had some vision to begin with. There was neovascular glaucoma and ptysis that developed in 4 eyes, but 15 of the 16 eyes were salvaged. There was a thought that perhaps earlier vitrectomy, the group that received the vitrectomy earlier in the course, might have a better outcome as there was less vitreoretinal fibrosis and less traction in those cases in the long run. It just makes me think that this is a disease that we can't let get to the 3B stage. And so we just have to figure out, I think, ways of screening babies and young children better than we are now. And I salute Darius Mashfegi and his co-workers who have tried screening tests and are proposing this, as I do think this is something that might be a way for us to prevent blindness from Coates disease in the future. So of all the causes of permanent vision loss in Coates disease, unless we can get to this early, catch it, treat it before the macula becomes involved, there's not, a lot of these are very difficult to reverse. One, though, I think is macular fibrosis, where I think we have some hope. And that brings up case number 3. And this is a 12-year-old boy who has poor vision with like a stage 2B. You can see here before treatment, he has quite a bit of exudate in his macula and serous detachment and some intraretinal edema. And 3 months after treatment, it's looking better as far as the OCT is concerned, but you can see there's increased exudation or increased lipid deposition in the macula. The vision's improved somewhat. Three months after that, now 6 months after the original treatment, something has changed in the macula. There was no leakage to begin with in the macular area, and now there is. Well, what's gone on? You can see here, there's a fibrotic scar in the center of the macula. There's a pigmented spot in the center of the fibrotic scar. It looks like vessels are diving into that area where the pigment is, and this is all centered in the area of the greatest exudate deposition earlier. So what's happening with the angiography? You can see here it looks like a retinal anastomosis has formed, and there looks to be abnormal blood vessels and choroidal neovascular retinal angiomatous proliferation happening within the retina here, and with leakage late. So we call this, or it's been described as macular fibrosis in Coates disease. I looked at the patients in our practice over the time our practice was in existence at the time, and 47 patients who had adequate imaging were sort of looked at. And the conclusions were that this is very common in Coates disease, this macular fibrosis, that it occurs at the point of the exudate accumulation, and it's a neovascular process, and it portends a worse visual prognosis. So this is another example of a case in which we have neovascularization happening right in the center of the macula. And it turns out that of the 47 patients in our series, we had 23% or 11 eyes who developed this exact phenomenon. And it's always sort of at the area where the exudate was most dense. There's usually within and underneath the retina. And there's this intraretinal vascular anastomosis that had been identified in 7 of the 11 eyes. There was hyperpigmentation oftentimes at the point of anastomosis. And this is something that was reported originally in 2010, and it's been some other co-workers or authors have found similar findings in their Coates patients. And Eric Sigler and Dr. Calzada both, they found that their rate was around the same as ours. 24% of the patients that they studied had this same macular fibrosis. The lower author, Dariush, has proposed that the presence of a subfoveal nodule be included in the Coates classification that was proposed by Shields. So what is the pathophysiology of this fibrosis? Well, it seems that phospholipids are a stimulant for inflammation that are there, and that this inflammation is a stimulant for angiogenesis. This is my sort of guess on all of this. This is Larry Iannuzzi's paper on retinal angiomatous proliferation, and I think the same sort of thing is happening here from the top down in our case. And you can see in our patient this area where the anastomosis is occurring, much like a retinal angiomatous proliferation lesion. Now, this is not isolated to Coates disease. This can happen in any exudative process. This happens to be a patient that Alberg had reported on with von Hippel disease who developed macular fibrosis after severe exudation. There's also macular fibrosis that can occur in diabetic retinopathy, and it's kind of interesting looking back at the ETDRS study that 1.8% of patients had choroidal neovascularization or a neovascularization process happen during the course of the ETDRS. And it seemed that the extent of the hard exudate was the strongest risk factor. At the time, they proposed that this had something to do with the laser treatment, that the laser was creating choroidal neovascularization in these patients. But 34 of those 109 eyes who had this process had not had any laser. They were in the control arm. And of those patients who were treated with laser, 92% did not have the choroidal neovascularization kind of associated with the actual laser mark. So it's, I think this is a case where the exudation is creating neovascularization. Well, in more recent diabetic research, they have been looking at the effects of anti-VEGF therapy on retinal hard exudate in diabetic macular edema. And in the exploratory analysis on RIDE and RISE study patients, monthly intravitreal ranibizumab resulted in significantly greater reduction in hard exudate as compared to sham. And in contrast to the rapid decrease in edema, this was a much slower process, reduction in the hard exudate. But it gives me hope that maybe there's something that we can do to reduce the hard exudate, which is the nidus, in my opinion, of the neovascular process. Well, this brings up case 4. So I've already dealt with case 3. He came and went. But now I've got case 4 in front of me, and he's got just as much exudate in his macula as case 3. And so and just as much subretinal fluid and all. So what I did on this patient was begin anti-angiogenesis injection therapy during the course of the exudate resolution, which usually happens, that I've seen, over several months, and usually requires about 5 injections about every 6 weeks to sort of get through that period. And you can see here, as the exudate is going away after 6 weeks, and then 23 weeks, and then 32 weeks after, and then we get into 6 years and 7 years, there is a reduction in the kind of fibrotic, but not complete resolution of the kind of a nodule underneath the retina, but it does not appear, at least clinically, to be as far along and as bad as what happened without treatment. But I am completely open to this being just the natural history, and that I didn't do any good with the anti-VEGF injection therapy, but I'm hoping that we are doing something to help these patients' eyes. And this patient had a good outcome. You can see here not a big scar and no retinal anastomosis that I can see on examination of this patient now, almost 8 years later. This is another example of a patient who received 5 bevacizumab injections over about 6 months. Over about 8 months. And this is a picture taken at 1 year after initiating therapy. So the other interesting thing about this kid has an unaffected identical twin brother. So it sure would be nice to get genetic analysis on this patient and his family, and we did. And so this just is a segue into the genetics of coats, which I don't have any answers for you, but I'm intrigued, as most of you all are as well. It all started with me with a paper that was by Black and his co-workers out of England, who found that they happened upon a patient who had Coates, a woman who had Coates disease and a Coates phenotype, who gave birth to a child with Norrie disease. And then in looking back at the genetics, it found out that her mother had an NDP mutation and she was a carrier. So then they then looked at archival Coates tissue from their tissue bank of Coates disease patients, and they found that one of those 9, they could find an NDP mutation, a somatic mutation in some of the tissue. It was present in the ocular tissue, but in the retinal tissue, but not in non-retinal tissue in this eye that they studied. So maybe there was sampling problems and they couldn't find it in others. Maybe there was a sampling problem and they found it where they shouldn't. I don't know, but it's intriguing that we're talking about the possibility of a somatic mutation. I think it's much more complicated than this, but it started the whole idea of genetics in my mind, at least. So there has been developed a Coates disease registry, and this is a multi-center effort, and thanks very much to the efforts of Emmy and Drs. Lee, Recchia. We have partnered with the Jack McGovern Coates Disease Foundation and Genentech and have performed whole exome sequencing and gotten data on 61 unrelated probands and 112 first-degree relatives. And we have complete trio data on 26 families at this point, and this is what we're working very hard to get kind of mother-father proband data on more of these patients. And the collection has yet to be completed, but we're very excited that we now have one of the largest whole exome databases for Coates disease that we hopefully will learn something from here in the future. All right. Case 5 is our 32-year-old man who at age 26, 5 years previously, had been treated for Coates disease and has new distortion but good vision. And these are images from 5 years earlier in which there's some mild exudation in the superior temporal periphery. But when you look, and this is not easy to see, but on the screen left, there is the original area, which then turns out to have the new Coates lesions and exudation later, now 5 years later. It's not very impressive. You wouldn't have treated it back then, and I don't see much in the way of leakage at that time. There's another example of a patient I saw just a couple, 3 months ago and retreated, is a young boy who has, again, he was treated in 2011, and now here, going on 8 years later, he has in an area where you can see on angiography by the arrow, really not much going on that turns into be a real exudative component there. So late recurrence in Coats disease after initially complete therapy has been described in up to 7% of Coats patients, and the mean time to recurrence is as long as 10 years. So that's why we need to keep following these patients, and that we've got to remind our patients that they need to keep being watched because there is a chance of a late recurrence. So in conclusion, our cause remains unknown for Coats disease. The vision loss is too common, and we definitely need more effective screening, and it's going to be the people in this room that will make that happen. We need further study to prevent this macular fibrosis, and I'm excited about the possibility of pharmacotherapies to do so. That macular fibrosis is a neovascular process and fairly common, and it's, I think, potentially a way of preventing vision loss in patients with Coats disease. And I think that the phospholipids may have something to do with promoting this inflammation and angiogenesis. It seems that peripheral ablation of abnormal vessels in ischemic retina is the main form of therapy still. Laser's effective, and even in detached retina, and multiple sessions may be required if you do that. And I'd say be cautious when using cryotherapy. And Coats can recur in a previously normal appearing part of the retina, so long-term follow-up is needed. Now, I want to give special thanks to Emmy, Layla, and Cindy. This has been a wonderful course, and I can tell that it's really been a big part of your life for the last year and a half or so, and I know that it's really been a tremendous success. I also want to thank the Jack McGovern Coats Disease Foundation, including the McGovern family, Deborah Marin, and the board. And I want to point out to the people in the audience that there's a website, coatsdiseasefoundation.org, and there's a couple things that I'd like to direct you to on the website. Number one is that there's a place in which you can sort of identify yourself as somebody that takes care of Coats patients for those who are on this website, and this website is indeed frequently visited by patients and families. And then also, there's a patient registry that I would encourage your patients to consider being a part of. As this genetic efforts get going further, that would be a good way for us to recruit patients. So thank you very much for your attention. Yes. Time for questions. Yes, sir.
Hi, Mike. It's Army Harper.
Hey, Army.
Mike, they did a big study in England looking at it's a twin study on Coats, and they didn't find any genetic association between the twins. Do you want to comment on that?
Yeah, so there have been some genetic studies looking, because there's some sort of candidate genes that people were looking for, and even in the Wnt signaling pathway, there has been nothing really shown to date that indicates this is a genetic problem, at least a germline genetic problem. I still hold hope that there's got to be some sort of downstream thing that's helping with the maintenance of vessels in general. And I do think that Genentech has taken this project on and done a lot of whole genome sequencing, and I think that they're doing so because they have a hunch that vascular maintenance, we could learn something from this little disease about vascular maintenance that might pertain to diabetes or other vascular diseases. Nina.
May I ask you a question?
I'm sorry, yes.
Here. I'm Dr. Ozek from here, with the moderator site.
Oh, sorry. I was looking hard.
That's okay. You have shown a very nice case with anti-VEGF, where you don't have any nodule. A nodule didn't happen, it didn't form, with just anti-VEGF injections. Is that correct?
Well, they were treated with ablative therapy in the periphery, but they were treated with anti-VEGF.
Together?
Well, yes. The ablative therapy I think of as being the thing that stops the peripheral exudation. Mm-hmm. And the anti-VEGF, what I think of is that the idea is to keep that exudate from turning into neovascularization in the posterior pole. I have not seen great results with anti-VEGF in causing sort of exudation to dry up without laser, but that was my idea. So
That was just 5 injections, or you continued
it was
with
5 injections done over about a 6 or 7 month period in a, done about every 6 weeks.
And I feel so when you combine the injections with the laser, it helps, but it's difficult, for the children to give injections under anesthesia. So that's why I'm concerned how many you did. Thank you.
Yes.
So Mike, great
Yes.
great talk.
Oh,
over
thank you.
here.
Yeah, Nina.
Yes, great talk. But the most interesting patient I have with coats is a 70-year-old guy now who came to me. I follow him for 20 years, and in those 20 years, he pops little areas of telangiectasia that we treat with laser, and he also had a slight vitreous hemorrhage when he had a PVD. But throughout 20 years, it's been great to follow him because angiographically, he just pops little areas that we treat.
Yeah, I mean, that's something that makes no sense to me. I don't get it. So, yeah.
Of the nasal retina. So I think, I'll repeat that. For cases of late recurrence, what I've tended to see is under treatment of the nasal retina, the tensions on the temporal retina. I think that using ultra wide field, either RetCam or Optos imaging to try to identify all those vascular changes and nuking anything that looks even slightly abnormal gives the best chance at avoiding late recurrences.
I agree with that. That you can get late recurrences in de novo areas, but you can also get what he's saying. I think is just progression in a sort of quiescent area that had vascular changes to begin with, and if you really do have to look for those. Yeah, and it keeps that VEGF drive going. Maybe, Mike.
This disease and familial exudative vitreoretinopathy, when it gets ahead of you, and you got exudate, I think are the perfect examples of that penocytotic leakage that I mentioned in my talk. And what you were just saying about the anti-VEGF therapy didn't seem to add that much. It's kind of instinctive that with this type of leakage, we would think anti-VEGF therapy would be something to do because we think of anti-VEGF therapy and control of leakage. But this is a perfect example of why normal healing fails to treat really severe leakage. It's a really, really fantastic demonstration.
Yep. Leila.
It was just a beautiful lecture. Thank you. Very informative, very interesting, intriguing questions. We recently did an institutional review of all our cases, Coats disease, and kind of treatment over the period and over the decades in terms of how our management has changed, and very much along the lines of what you've talked about. But we also did kind of some indices of OCT findings, what we can see in Coats. And it was interesting to find out in cases where they show beautiful exudation, intraretinal and subretinal, we found out, just like it mimics in diabetes and other disorders, that intraretinal exudation typically does not limit visual acuity down the road, but subretinal definitely tends to clump, like you showed, and potentially creates a nodule. But I think your case very well illustrates potential use of anti-VEGF to limit the nodule formation, or at least vascularization of it. I think in that particular case, it looks like the kind of fibrosis did form, but luckily a little more in perifoveal locations versus subfoveal. Now, the question for you is, any pointers how to decrease the amount of subretinal exudation as it takes place as we're treating? Because sometimes we find out that treatment actually provokes it, and what are your pointers to limit that? Because that's actually, at the end, the limiting factor in visual acuity benefit.
Yeah, I think that the exudation, when you see it increase like we did in the third case, the exudation was there, it's just now falling out of solution. And so it does increase the amount of exudate which you see that's present. And when it falls out of solution like that, I don't know that there's anything more that can be done. There's been talk that I don't believe, maybe others could comment on this, that perhaps if you laser somewhere out in just posterior to where the actual vascular changes are, that you might decrease that migration of exudation. But I don't know that, I don't believe that. Another thing that has been shown that Golem Payman, who is such a fantastic mind, he has done actual subretinal surgery to remove exudate in Coates patients, but I don't think that that's that wise either.
Mike, that was a terrific talk. You know, when you showed the images of where there was vascular, where there was a recurrence, and then you went back and you said this is where it was, and
Yes.
we were all like, oh my gosh, I wouldn't have seen that or treated it. You know, as the resolution and some of our imaging improves, right, or the ability to see better, whatever the optics are, we might be able to pick up things like that earlier.
I agree. I think that OCT angiography could be a very good way of picking these up. When we get swept source, more wide field OCT angiography, we're probably going to see a lot more things. And I think just like Mike has pointed out and taught me about fever, this lapel area, you know, you can see that in Coates disease where you have, you know, there are vessels going through it, but there's nothing feeding the retina right there. And to me, I think that that's an area that may be driving further exudation that we have to pay attention to and do something about. Maybe give Norigen, TM.
And Mike, you said you give 6 injections. So at what point is your decision to stop?
Well, you know, it's a very easy endpoint. It's when the exudate, when I feel the exudate is cleared enough that it's not going to turn into neovascularization. And that's I mean, a lot of exudation has to go away, you know, but I feel like over time with Coates disease, I've gotten a feel for how much exudate it takes to create this fibrotic scar. And so if it starts breaking up and thinning out, I feel like you're in pretty good space.
Hi, Edward Wood, Royal Oak, Michigan. Dr. Jumper, great talk. One thing I was thinking about for your twins is it could be interesting to look at epigenetic sequencing in addition to whole exome sequencing. That can provide some good information.
I think I actually have two twin boys, which are affected, both identical. And so that is one of the things that we're working on with the Genentech and the Jack McGovern Coates disease people. Yes.
I have a question here. I have to admit I'm not a Coates expert, but I would like to ask you, when you're talking about the macular fibrosis, what histological evidence are there that there's actual fibroblast involvement? And I ask that mainly because the imagery that you've shown is, I guess it reminds me of the processes that our lab has been doing some work which we haven't reported at this stage, but we've been looking at drusen formation in infants, like from a series from, I guess, an IBank series. Mm-hmm. And we've seen drusens from age 9 years onwards. And I guess I'm trying to differentiate the pathogenic process in Coates disease between, and the separation and the exudate deposition underneath the RPE and then the choroidal neovascularization. It's reminiscent to me of possibly a slightly different, like as the RPE separates, you've lost the digestion, that RPE role of digesting the photoreceptor outer segments. So I'm trying to sort of think about the pathogenic processes in terms of slightly different to, I'm a angiogenesis person, so I love that mechanism, but I guess I'm also asking you in terms of drusen formation and the separation of the RPE and how that affects the deposition that you're seeing in Coates.
Yeah, I mean, I feel like the separation of the retina and the retinal pigment epithelium shouldn't be enough of a drive in itself to create neovascularization in this situation. We have people with central serous retinopathy and have, separation for months that don't get this kind of a complication. I really think that the phospholipids sort of between the retina and the pigment epithelium have something to do with this. We know that recruits macrophages, and we know that macrophages have an angiogenic component. So I'm not sure if I am following your question other than what I just said.
I actually do agree with you. And part of the drusen contents that we're seeing is that there are lots of fatty lipids
Sure.
as well as the macrophages. So I guess that there is an overlap in the pathogenetic processes. That's all I'm saying.
Yeah, I think you might be right. Yeah.
Excellent. Thank you very much. That was fabulous. That was very fabulous.